I'm Dr. Michael Janssen at the Center for Spine and Orthopedics in Denver, Colorado. I've been a spine surgeon here in the North Denver geographic area for about 25 years. And this morning I wanted to give you an overview of lumbar spinal stenosis. The goal would be to define what spinal stenosis is, to talk a little bit about some new and advanced technologies that have come around in the last few years to assist in managing spinal stenosis, and to try to help decide if this is something that you're suffering from, your family member is suffering from, and what's the best treatment for any phase of your illness and or spine injury. At the Center for Spine and Orthopedics, we are a center of excellence that dedicates our entire practice and all of our patients and all of our staff in managing patients that have suffering from spine conditions like this. We also have a full research department to evaluate a lot of this technology so that patients are getting the right technology at the right phase of their injury and or disease and or symptoms they suffer from. Spinal stenosis. What is it? Well, spinal stenosis is simply a disproportionate size of the space available for your spinal nerves compared to the spinal nerves themselves. I tell patients it's like having a size 9 shoe or 9 foot and jamming it into a size 8 shoe. It's going to hurt when you go walk. Now, if you have a pair of thick socks, that even makes the stenosis even worse. So the goal is just to try to find ways to manage patients to decrease their symptoms by making more anatomical or physiological room for their spinal nerves. That's really what spinal stenosis is. It's a disproportionate size of the spinal container versus the contents. Many patients walk forward or flexed forward to make a little bit more room for their nerve, and sometimes at the grocery store you see an older patient that grabs an older man or woman grabs a shopping cart, leans forward, and they can walk much further because they're able to make a little bit more room for their nerves by changing their body posture. So let's talk a little bit about the pathology and what happens. Well, first of all, humans were meant to walk upright, and the body of the human, the discs are somewhat like a shock absorber, but that changes over time. The picture on the lower left shows a woman at age 50. The same woman at age 75. The discs have collapsed. She's slightly more angulated. She has a little bit more of a kyphosis, we call it. And usually those patients start leaning forward to make more room for their nerves. Their spine is degenerating at the same time. And that's what gives the patient some of these symptoms of spinal stenosis. Excuse me. So sometimes if the patient gets better because they flex forward to make more room, there's been a whole lot of technology in the last 5 or 10 years called interspinous devices. These are all little implants that can be put in through a minimally invasive approach into the spine to actually flex the spine forward and hold it there, very similar to what the patient does when they grab a cane, or they grab a walker, or they grab a shopping cart to try to make a little bit more room for their spinal nerves. What it does, these devices, is they reduce the pressure on the disc, they unload the facet joints, they increase the area available for the spinal canal, and they increase what's called the space in the foramen, or the foramen around the nerve. They sometimes tend to improve patients with back pain. It's not as predictable. They can improve patients next to a fusion, not as predictable. And they can unload the facet joints, but again, it may not be as predictable as what this technology is primarily designed for, which is for patients with spinal stenosis. Now, different devices do different things. The back, the most posterior part of the spine is called the spinous process. And these implants go in between the spinous process. This implant, you can see, goes in the spinous process and has these ropes, or that white tape. It's a very strong kind of a rope material that goes over the top. That blocks the motion, so it doesn't allow it to move. These devices, one looks like a hinge, the other looks like a dampening pillow. They allow dynamic motion, but they control the motion. So it's completely different between dynamic motion and blocking the motion. And at the same time, each of these devices, which have been different surgeons have different experience, and at a center of excellence like the Center for Spine and Orthopedics, we've evaluated all of these technologies. Some of them allow a patient to have flexion, some restrains flexion, some allows extension or going back, some controls extension. So you need to really make sure as a surgeon that you're finding exactly the right device and the technology that any particular patient may or may not need. This was a study that was done a number of years ago on one of the first devices called an X-stop, and it's an indirect decompression device. So this device was placed between the spinous process into 100 patients where it was semi-flexed forward, and it had really good early on clinical improvements that the reoperation was quite low in the decompression group, and most of these patients tended to do relatively well compared to that of the standard techniques that were utilized over time. But here's how it works. This is looking at a cross-section or an axial view of the spine. Similar to cutting a tree down, and now we're going to analyze a tree stump. You can look here at the spine and you can see the amount of the space taken up by the spinal nerves. There's a thick ligament around the spinal nerves, and there is a small area that the spinal nerves get compressed. When you put an interspinous device in, where this yellow area is the canal area of 18%, you can see that the area in red was an interspinous device went in, which flexed the spine slightly forward and made a little bit more room for the nerves. That's really not much different than doing an injection, where hopefully the goal is to decrease the space or the edema in the nerves. So both of those tend to work relatively well. We have found that about 9 to 10% increase in the diameter of the spinal canal, but when you have a device like that, and that's about what 9 or 10% means. Sometimes that's all that it takes to decrease the symptoms in these patients. Now, a patient with severe stenosis, it doesn't work. By also flexing forward, about 50% increase in what we call the subarticular diameter, and you can see here we've outlined that. That shows a little bit more room for the nerve at each of these. Some of the other technologies that we've seen that's come around in the last decade is called facet replacements. It's not as exciting and hasn't done as well as disc replacement surgery, but it is an alternative in some patients at the right phase. It's a big mechanical device. This is a patented device. The problem I have with these devices is fairly destructive. In 2016, a surgeon has to go in, we have to remove all the bone, remove the facet joints, put this mechanical device in that's going to supplement the facet joints. So it's a pretty destructive operation and aggressive in a patient that maybe do better with just a small fusion surgery than some mechanical device like that. But they're out there, and this is another example of screws going in the vertebrae attached to articulating devices that creates a mechanical or an artificial joint in the back of the spine. We probably will have a better understanding of how to use this in the next decade or so. We've ran a lot of these in our lab at the Center for Spine and Orthopedics, evaluated them in clinical trials. Today, in 2016, the time of this filming, I'm not a big fan of this technology, but I do think it may be something we will continue to explore and find out if there's a good role for it. Here's another interesting device that someone came up with, to place a little screw with a washer across the joint, which really doesn't fuse the joint, but it dampens the joint. So remember, part of the stenosis is due to thickening of the joint, and if you can control the motion, it may benefit the patient. But in my mind, a device like that probably may last the patient for 6 months, 1 year, 2 years most, and then it would probably need to be removed and converted to a fusion. So maybe it would be better to do a single surgery than to try to treat a phase. An exciting technology, though, is called dynamic posterior fixation. Typically, when we put screws and rods in the back, we fuse the spine. In this case, we're putting screws or rods in that allow it to move, called dynamic type fixations. And you can see each of these either have a hinge on them, they're made of a plastic with a core inside. They control motion, kind of like putting a brace on a patient externally, controlling motion to some extent, and that's called dynamic fixation, and it may have a role in patients. So is there a need for any of this? Well, This bottom picture shows a cadaver spine that has stenosis. The thick yellow is the ligaments, the brown in the center is the cauda equina, the disc is right above that, and the facet joints are worn out, and those patients probably need something. And in an anatomy like that, they either A, we could try to give them some therapy and core strength. B, we might try some steroid injections to cut down the size of the nerve. C, we might try surgery just to remove the ligaments and make more room from the nerve, or try some of these newer technologies to treat a phase of the disease to try to benefit the overall patient. And maybe sometimes when a patient has a disc herniation, as you can see in this MRI in the bottom where the disc is given out and extruded in the canal, we may have better technologies than just trimming off a piece of the disc. So in summary, with these rods, some of them allow motion. These right here, they block motion in compression. And some of them are dynamic that allow flexion and control compression, but then they may allow side bending. So each of these are a little different, and not one technology meets all the patients. There's been about 10 years of publications that we've been involved with these types of clinical trials. I've circled some of the level 1 evidence, which is randomized, prospective clinical trials that show what the outcomes are at about 1 year. We don't have the long outcomes like we did with disc replacement surgery because these are treating a phase of the disease, and we may not have the 5, 7, 10-year follow-up as much as we have some of the shorter-term outcomes. I think in the future, we're going to have another great technology called nuclear replacement. That means the disc is worn out. The tire is worn out on your car. And maybe we'll have a device to be able to repair the inside of the disc without completely taking it out. And some of these are hydrogels. We've worked in our lab evaluating a lot of these. I don't really think they're ready today in 2016 for human clinical trials because what happens is when the disc deteriorates, the outside of the annulus is also deficient. So if the outside or the container is deficient and we put something inside that will dampen the load, we're all going to wonder and worry for our patients that is the disc healthy enough, the outside or the container, to hold this device in place. And as we age and our discs deteriorate, is the container still healthy enough to hold it in place? And that's part of the unanswered question we just don't have good answers for in 2016. So when we look at some of the results compared to that of fusions and the complications, I think some of these interspinous devices, dynamic rods, facet replacements may be a good indication compared to that of patients that have historically we've done a fusion, but the jury's not out 100% to think that all of these are great for all patients. It's finding surgeons that have a lot of experience and understand this disease and are working in a center of excellence to try to find the right technology at the right phase of their disease for patients. Because I always think it's like this curve. A lot of new ideas come out in medicine and in healthcare, and we get a promising idea. Then there's some early publications, as you can see there, called encouraging reports. And then the news media picks it up, and everybody thinks a laser or something like this from a laser institute is going to be the best thing. And then everybody thinks it's the best treatment. Then someone starts publishing the complications and the problems with this treatment, because all these surgeons go to weekend courses or they go somewhere and they're not vastly experienced with it and have lots of complications, and then pretty soon it's gone by the wayside and nobody uses that technology anymore. And that's not the way any of us really want to be treated. You want to go somewhere and have your family taken care of at a center of excellence, that they have a lot of experience with technology, they have decades of experience as a surgeon to make the right treatment at the right phase of their disease for each individual patient as it goes forward, and really benefit the patients as they go along and not just have these technologies go along. And I think a lot of this stenosis technology has already gone through this curve and is an exciting option going forward. In conclusion, a lot of these non-fusion technologies we put in the back of the spine may decrease some of the fusions that we have done historically. Some of them allow motion, some of them control motion, some of them are very, very exciting, but there's not one individual technology that is really the best. And it's important to find a center of excellence that the surgeons have a lot of experience and decades of experience to understand what's best for any patient that suffers from a spine disease today so they can make the right informed decision. Hope that gives you an overview of spinal stenosis and some of the technology that we've seen come and go in the last decade and a half, and really what's best for the patients going forward. Thank you.